Good morning to welcome to Cardio-Oncology Conference of the International Cardio-Oncology Society. Glad to have everyone here. I think we have Nadine Graham, who's going to be our new staff here, and so we're glad to have her. Welcome Josh Podolsky, who's a member of our Board of Trustees. And we want to say welcome to Daniel Linehan, Calvert, Nadine, Pamela, and Superna. At this time, I would like to welcome Oase Bag, who is a Chief Cardiology Fellow at Largo Medical Center, who is going to present our case today. We're glad to have Oase here, who's on our Advanced Cardiac Imaging Service for an extended period of time, hopefully. Hang on just a second, and we'll give you now Oase.
Hello, everyone. Good morning. So we have an interesting patient that I'd like to present to you, patient SG. She's a 35-year-old female, history of breast CA at the age of 31. This was diagnosed when she was 6.5 months pregnant. She's a Caucasian female from Sweden. She's had 2 chemo courses of adriamycin. She underwent labor and delivery after said chemo, underwent surgery, radiation, reconstruction, was placed on Taxol for 6 months, Herceptin for 12 months, followed by radiation, and then noted to have a new left lower lobe lung tumor, and she was placed on Herceptin and Perjeta. History concerning her breast cancer began when she was 6.5 months pregnant. Initial diagnosis was made of mastitis, and she was placed on antibiotic therapy at that time. Biopsy was subsequently performed, and she was started on adriamycin therapy, again 2 courses back in 2010. She underwent labor and subsequently was placed on Taxol for 6 months, Herceptin for a year, and then radiation for 5 weeks. In April of 2002, she was found to have a new tumor in the left lower lobe of her lung. She was then started on Perjeta plus Taxol every 3 weeks. Additional history: she's got no known drug allergies, past medical history significant only for breast cancer-related events, mastectomy for placement and reconstruction. Family history: father, strong history of coronary artery disease, diabetes, and hypertension. As far as social history, she only drinks approximately 1 to 2 glasses of wine, only 1 to 2 times a month. She regularly exercises and does not use tobacco. She was presented to us as a second opinion given her various ejection fractions that had been reported during the course of her chemotherapy. As you can see here, we had quite the range, ranging anywhere from 33% up to normal range of 55 to 60%. So when she first came in, we started her initially on Corrigan and enalapril. She had multiple echoes that seemed to be fairly stable over the previous couple months prior to her seeing us. Her ejection fraction at the time seemed to be around 40%. Echo at bedside here in our clinic noted to have an EF of approximately 40%. At that time, we ordered a strain echo and cardiac MRI. So after initiation of Corrigan and enalapril, she began having symptoms of headache, lightheadedness. Some symptoms, when we went into her history, did seem to be present just prior to initiation of Coreg. However, she became much worse in terms of these symptoms. She did develop a dry cough as well from her ACE inhibitor. Strain at that time was noted to be minus 16.5% and an EF of 44%. After a long discussion with the patient, we decided to place her on drug holiday of beta blocker and ACE inhibitor until symptoms resolved. She was willing to try another beta blocker if she became symptom-free at that time. Follow-up 1 month later, we did do a repeat echocardiogram, and her ejection fraction was noted to be 37%. At that time, we had decided that we would consider starting Entresto, which was a new heart failure medicine which had just been recently approved, FDA approved for CHF. Patient stated at that time that she would like to wait and did not want to start any medication at that time. So then we followed her up again a few months later and noted that her EF had dropped 23%, MRI 32%. At this time, we noted that we needed to start her on medications and convinced her to start Entresto. We did start her on our low dose, and then 2 weeks later jumped to the mid dose. Oh, that goes to show that echocardiograms cannot be used exclusively in terms of quantifying ejection fractions. there are various methods that we use. MD Anderson's practice guidelines do recommend the Sampson method. However, various locations and various echocardiographers, various techs, all these things contribute to altered ejection fractions, and so the recommendation would be really to have the same cardiologist read the echocardiogram, the same tech, and ideally the same machine. So after we started her on Entresto, we did a repeat 4 months later of her ejection fraction. We noted her EF at that point to be 38%. The strain at that time was -13. We did recommend that she could continue her chemotherapy at that time. So these are the two strain images that I have. So this is the one from October of 2016. And if you note here, we do have some septal and lateral wall strain issues. Or lateral strain average here is -13.2%. And if you recall, we're looking for normals anywhere from between -18 and -22% based on the system that you're using. Subsequent follow-up, now that she's been on Entresto for approximately 4 months, revealed an EF of 55% and a strain of -18. And this is her strain. Pretty much doesn't get better than that. Would you agree, Dr. Harrison? And this is her MRI.
Let's see, Dan, do you want to tell us a little bit about the MRI and see what you think about this MRI?
The LV doesn't appear particularly enlarged. It might be at the upper limits of normal. Left atrium may be a bit enlarged as well. LV function looks pretty close to normal. I don't know what the measurements are. Tiny pericardial effusion. And then breast implants. That's about it. I don't know if there were any gadolinium imaging.
I don't see any gadolinium imaging for lead gadolinium enhancement, and usually we don't see focal scars that are large enough to be able to see anything, and so we're going to be doing T1 moly as soon as we tear down our platform and then build it back up on the magnet. We plan on doing T1 moly, and then we'll be able to look at diffuse small fibrous material rather than big pieces like you look for in terms of number of grams of tissue like we do with patients with coronary artery disease, sarcoid, amyloid, etc.
And just to clarify, there's nothing in her family in terms of cardiomyopathies in first degree or secondary relatives, right?
That's correct.
Okay.
Actually, a correction to that. She does have one family member that was diagnosed with cardiomyopathy. However, that was ischemic cardiomyopathy requiring multiple PCIs, and it was a male relative. I cannot recall exactly who it was. However, he was in his late 60s, early 70s when that was diagnosed.
Got it. Thank you.
So it looks like was the final measurement on the EF from the MRI acceptable?
So I'll tell you what we did. This was a lady whose husband is a personal injury attorney, and basically she seems to use that as a playing card, and so she has become very distrustful of the echo in terms of measuring ejection fraction, because she was seen by a non-cardio-oncology group of cardiologists, and each time she would come, she'd see a different cardiologist, and the echo would be done on a different echo machine by a different tech and read by a different cardiologist. And so it was just amazing the variation in ejection fraction that she had, and so we had to actually go for an average because they were just all over the place. So she became very distrustful of echocardiograms, and so when we said she had a low ejection fraction of 23% on the echo, she sort of demanded to have an MRI. And actually at the time our workstation was down and we were getting a new workstation. And so we did the MRI and then we had to send it off for like 3 different measurements of the ejection fraction off-site, which there are off-site services, and there was one in Seattle that we used to be able to get that information. And so then we got 3 ejection fractions, presented that to her, and then she was satisfied. So it was real interesting, her take on echocardiography in a single practice. And you can imagine the variation then among many centers where patients are sent each time to a different center because most oncologists don't have echocardiography. So frequently the lowest bidder, and not infrequently sometimes to a center that does imaging that has a tech that does gallbladders and abdomens, and then we'll do occasional heart, and then somebody will come by and put their stamp of approval on, and without any supervision of the tech whatsoever. And so the lowest bidder echocardiography then is thrown into the match to make decisions, clinical decisions on patients. And so there are large oncology networks that send the patients to the lowest bidder, and I'm not sure how they can possibly cope. And the first patient I ever saw was a patient that had a low bidder echo that was resulting in discontinuation of chemotherapy, and we had to trump that. And so we did an echo and an MRI and showed everything was consistent with the ejection fraction being normal, and that this was an outlier that was done by a tech that's unsupervised, that's not registered as a cardiac tech in a lab that's not ICAL certified, and so on. So it's interesting you bring that up about the ejection fraction.
No, it's a real issue, I would say, because if you think about it, I don't know if we have anybody from oncology on the phone or on the call, but it's just their perspective is to order the test and you get the result, and whatever that is the result, and they have to trust that the test is done appropriately. So I mean, it's like if you order a hemoglobin and you expect that when it comes back that the hemoglobin, if it was 13, that's a real value, and you make your decisions based on the hemoglobin of 13. But if you do an echo, an EF, and there's all these technical limitations, and it comes back low, then you withhold therapy or you do something different. It's a huge deal, and so the measurement of EF has to be done properly. That's one thing, but then the other is that we can't be dependent on such a variable number. There has to be more to the story.
Yeah, so that's interesting. So if you order a hemoglobin from Walgreens at Theranos, and retracted 20,000 of their laboratory tests that they performed recently, and so you really can't depend on hemoglobin sometimes. But in terms of echocardiography, I work with the largest private practice oncology group in the country that spans the entire Florida peninsula, and I have a relationship with 2 of the oncologists. The rest of the patients are sent out to outlying echo vendors of various expertise, and frequently not a cardiologist involved in terms of direct patient care, but only in the reading, sometimes the radiology readings, and so it's highly variable. And I don't know how they cope with that, because the first patient we saw was actually, she's really dear, and she's embraced our calls very dramatically because she was told her chemotherapy would cease because her ejection fraction had gotten so low, when in fact it was a false value.
Well, and then to take it another step further, so actually I think the first author was Yoon, Y-O-O-N, but the senior author was Ron Watellis. at Stanford a few years ago, and just looked at, how do clinicians respond to evidence of cardiotoxicity. And this paper was in, I think it was JACC maybe, but it was actually a nice paper. The thing that was particularly nice about it, in my opinion, was when patients got MUGA and they had an abnormal EF measurement by MUGA, the rate of engagement of cardiology was under 20%. So you'd have an abnormal test, but because it was just done by, radiology, and it was just a test result, there was no response to the LV dysfunction. As opposed to if you did an echo and you had a low EF, then cardiologists who read the echo would get engaged at a rate of about 60%. So the big difference was, which test did you do for monitoring? So there are advantages to doing echo because, you will engage a cardiologist if you see an abnormal value. However, there's also the limitation of, the EF measurement itself has its own technical problems.
So it's Joe. We've done this for a couple of years, once a month. Lots of very interesting cases, lots of data and learning. But from the standpoint of making a practical impact on the world, this might be the most significant presentation we've ever had, because I echo, excuse the pun, this same experience that outside echoes, even outside MUGAs, more often than not, are totally inaccurate, and people make decisions. And I would just like to reinforce what I assume everybody does, is never make any decisions based on some outside report, but to and because we try to save money, we spend a lot of time getting discs from other places and reviewing them before making any decisions, and before even spending any money to repeat. I think this was a great presentation.
Great, and so that's a good point. And so we have the downside of MUGA also. And so if you've ever been with a MUGA technician and you watch the acquisition and you've seen the images and you've seen that little small thing that's on the screen that someone's setting some limits to during systole, and then they're setting new boundaries during diastole, and then they're using that as a measurement, you will feel that measuring MUGAs also has the same plus or minus, what do you want to say, 7 to 10% error that you see with echo out in the community. I think you can get better with echo if you have 3D echo, and you can do better measurements with that third dimension rather than living in flatland. We left flatland about 10 years ago, and so we're living in the three-dimensional world, which brings us to CT scan and brings us to MUGA and PET. And so I think there's a lot to be said with 3D imaging of everything, so that you can get into that zone of plus or minus 5%, and then you throw in the same technician, you have the same machine, you have some standardization. Perhaps if you're in a big hospital, you could have a dedicated tech, and perhaps you could have a dedicated machine for cardio-oncology. I don't know if that's possible, because if you throw somebody into a large medical center and they've got maybe 7 echo machines roaming around through the hospital corridors, and they've got techs that are on and off, and various degrees of competency, and they've got trainees, it's going to be very difficult to reproduce the same stuff, that you got before. And so that's why we have, a dedicated machine here in the office, and we have a tech dedicated in the office. And by the way, it took us 4 years to be able to get a credible strain. And we really didn't get a credible strain until we started doing CT MPI. And then we had something to base it on. We had we had something to use as an anchor, and we could compare one to the other, and they were sort of holding hands, as opposed to being floating out there in nowhere and trying to say, well, does this strain make sense or does it not make sense, and not having anything to base it on or compare it to. And so first our tech went to MD Anderson with Dr. Bonches, and we actually sent 2 machines in from 2 vendors at the same time to join the machines there from various vendors, and we compared one to the other and saw the variability at that time and how severe it was. We also saw that there were, at MD Anderson, there were different techs doing different things. There was one tech acquiring the image, there's another tech post-processing, and there was another tech drawing the strain, and so we had 3 techs doing the job with 3 different people that could make an error, and then read by a superb physician, Dr. Bonches. And so we learned from that lesson that was making something that seemed pretty simple, very complex, and building in 3 errors in a row rather than just having 1 error. So that was kind of interesting. And so then we worked with Dr. Marwick, who was at Cleveland Clinic and then moved to Hobart, Tasmania. Tom Marwick, who's probably would be characterized as being Dr. Strain, or maybe the father of Echo Strain. And so we worked very closely with him, and he helped us with our training too. But it took us 4 years to really standardize strain that we're really comfortable with it, which is interesting.
I think the other part is that the point that I was making about that prior article is, so even if you say, you know, an MRI is a better test, which, you know, maybe not, but certainly MRI is a good test, but not all patients can tolerate an MRI, and then, you know, not all patients are eligible because of creatinine issues or whatever. But then the next step is also, if you have an MRI, even if it's done perfectly, but it's read by a radiologist, and, you know, there's never any input from a cardiologist in terms of what the meaning of the findings are, then I think you really miss out. If you're focusing only on a test, then we're going to have a lot of issues. It's the cardiologist contributing to the interpretation that I think is critically important. And that's where this previous article showed that when a cardiologist was engaged, they were more appropriately treating the LV dysfunction, for example, that was found on the test. So I think that it's not so much that the test is done perfectly, it's that the cardiology person is engaged in the patient care, especially if there's going to be a big decision made.
Yeah, that's good, Dan, because I've used that same principle in the emergency room in evaluating patients with chest pain. So I had to put a standard group of orders together and come up with an algorithm, and so my algorithm put early acquisition of an echocardiogram on patients with chest pain, and one of the reasons is less than 1% of acute coronary insufficiency has a normal echocardiogram. But the other reason is to get early engagement of a cardiologist in evaluating a patient in the ER with chest pain, and so that certainly ensures that will happen. And so I use the same trick that you're talking about. So Zaza, do you have any comments you'd like to make? Zaza's in Israel. Hello, Zaza.
Hey, how are you doing?
Very well. Do you have any comments you'd like to make on the echocardiogram? Zaza's coming in on the phone now. We lost him on the mic. How about Sebastian? Sebastian, do you have any comments you'd like to make from Poland? Zaza.
Hi, everybody.
Hello.
Congratulations for this day and your presentation. And we have in Poland MRI imaging for our patient, but we can't use this method in daily practice because MRI is too expensive for regular daily practice. So if we have the patients with difficult abnormalities in echo, In this situation, we can use MRI, of course. And I can confirm that MRI can conclude the value, which value of ejection fraction we have. In patients with borderline ejection fraction, this method is the best for our clinical decision. For example, for patients, for women with treated with trastuzumab, and we can conclude when we can continue trastuzumab and when we should stop the treatment. And MRI is very, very helpful. And the second situation is the patients with when we suspect the infiltration of myocardium, especially the patients with lung cancer. We have the many situations when we can't expect the infiltration or endocarditis during chemotherapy, and of course MRI can conclude and can differentiate these problems. So I can conclude that MRI is helpful in our patients, but is too expensive for regular daily practice, in Poland of course.
I just wanted to chip in one thing just to dovetail off that comment. I think the powerful use of imaging in monitoring these patients is watching for serial changes. And even here at Penn, we don't use MRI to measure serial changes in EF. We use our handheld B scans in clinic, our formal echocardiograms, and then we also use biomarkers, changes in NT-proBNP, and then of course clinical exam and volume status. But I think the MRI is a great anchor point when there's discrepancy, but I echo that, pardon the pun again, Joe is clearly influencing me here, that MRI is, we still use echo as the backbone of our EF measurements here.
So it's Joe, you know, one of the things that, one of the things that
Ron, I hear you, but we got two people talking.
Okay,
so
go ahead.
Who was talking before?
No.
Well, I
was going to say that with MACRA coming and the question of cost effectiveness, and we ought to begin to think about what the best way to do this monitoring is, because facilities are not going to be able to sustain themselves doing echo, MRI, CT scans on everybody all the time and repeating them multiple times. So at some point we ought to think about the economics of how we can make cardio-oncology fit into what our hospital administrators are going to come and tell us we can and cannot do because of payment systems.
The question
that's a good point.
I'm sorry.
The C students are telling us what to do nowadays, unfortunately, and so we've got the bean counters out there checking everything. One of our answers to that in terms of the HCA healthcare system is to develop a core laboratory with a hub and spoke system. And at our core laboratory, now we're basically becoming engaged with IBM Watson as a controlling factor to give us quality analysis as we train it with expertise. And so we're hoping that the core laboratory concept can be proven to be financially viable and to assist physicians in pre-digestion of the imaging information, and so that just like the GE Muse system does on the EKGs, there's a pre-digestion by supercomputer and cognitive computing to get information that then they will basically look at and sign off on. And so that's our answer to that, Joe.
Yeah, so, there was I think it might have been in JACC, or it might have been in the American Journal of Cardiology, I'm not sure, about the development of a Muse-like system to actually pre-read echoes as they're generated. I don't know if anybody saw that, but it was kind of interesting in that, I don't know, 20 years ago, nobody would have said, we all would have said that a computer reading cardiograms is not accurate and a waste of time. But we're at the same point with doing the same thing with the reading of echoes.
So that's what we're doing with the cardiac CT. We decided to start out with cardiac CT.
Hello.
Let's see, we have Ron Crone who has his hand held up. Ron, would you like to speak?
Yeah, I thought I'd do it legally here. A couple comments. One, I just gave a talk actually to the oncology fellows, and we made the point about the variability and the importance of this. And we've had a meeting with I'm not an echo person myself. I had a meeting with the echo guys about strain, and I think everything you said has been echoed. I can't use it. Get away from that word. Echoed here. But the other thing with MRIs that I've been fascinated with is diagnosing myocarditis. And we had a guy with carfilzomab who actually had aortitis and a troponin elevation. And when we did an MRI looking for myocarditis, sure enough, he had it. He had patches of fibrosis, actually, or edema, throughout the heart. And it didn't do much. We just sort of stopped these carfilzomab, and he's gotten somewhat better. But he also got a lot of steroids because of the aortitis, so it may have had an effect on the myocarditis also. We have another person with trabectedin, who I just thought I'd pick everybody's brain, who has a troponin of like 8, 46-year-old man, normal coronaries by CT angio. And we're thinking about getting a MRI here, again, looking for a myocarditis. I wonder if, we don't have to worry about the ejection fraction here because it's down a little bit, but it's not going to be there are other reasons for not treating them. But I just wonder if anybody has experience with using MRIs for myocarditis and even following it that way.
Yeah, I think the MRI is potentially a useful test for myocarditis, but I have to say I'm not convinced. I've seen too many cases where I was for sure suspicious of myocarditis that didn't show any real diagnostic findings on MRI. So
we're not biopsying it, so
yeah, it's a good test, but it's not perfect. And I think that if you had a troponin of 8, that's substantial, and you should be very worried about that.
Rafael Cepeda, who's had his hand up for a while. Rafael.
Hello. How are you? Can you hear me?
Good. Yes.
Hello, how are you? It's good to hear you again. I'm Rafael from Mexico. How are you?
Fantastic.
I have a little comment about the congratulate for the presentation. I have a little comment. With the MRI, it's a very good point that you say that about the cost and about the not being so practical to do in these patients with the cardio-oncology problem. And the other thing is that we need to remember that in the guidelines they say that there is a lack of delayed enhancement in the myocardium with this myocardial dysfunction related to cancer treatment. It's one thing that we need to remember. I mean, when we do MRI, it's the best test to see left ventricle ejection fraction. But the thing with this is that we don't have the late enhancement. Maybe we can tag and do a strain with the MRI, and we can tag, but we need to admit that it's not very
Hey, we're going to move back to our principal speaker.
I mean, we don't do that a lot. And the lack of the late announcement is the thing that I believe that The thing is, I think to do practical and very continue of the look and the measure of the left ventricle ejection fraction. I hope I can explain it well. Sorry.
Going back to our principal speaker, Oase has more to say, and so this is just the kickoff of his discussion. So hopefully we'll generate some more discussion as Oase continues on. Oase?
Hello. All right. So I wanted to talk a little bit about strain imaging. I know that we have discussed this in the past. You know, essentially back in 2010, the American College of EP Physicians actually and the American Society of Echocardiographers formed a joint committee to assess point-of-care echocardiography. And this is kind of how strain started kind of coming into the picture, especially in the and it was primarily function, chamber sizes,
Eric, we can barely hear him.
volume status, load, etc. And then also procedural guidance for pericarditis.
Muted.
זה גם, אבל evidence אפס, זה דעה. אבל זה מה שאני...
Unmuted.
As I mentioned earlier, the longitudinal strain is what's affected first, and that makes sense when you look at the longitudinal fibers being more in the subendocardial and subepicardial regions. So in the setting of acute heart failure, LV dysfunction may exist in any of the different planes, making it challenging to identify abnormalities using conventional methods. So early studies in patients with heart failure and preserved EF found impaired longitudinal strain with values that were comparable to patients with impaired LV function. Given the microscopic anatomy, existence of early impairment in longitudinal strain in patients with heart failure supports a conceptual model where cardiac dysfunction represents more than just a preserved or reduced ejection fraction. Impaired systolic strain, especially lateral wall strain, has been shown to be an independent predictor of adverse outcomes in patients with heart failure, even when accounting for conventional prognosticators such as LV function. Now, as far as normals, there needs to be more of a standardization between the companies, and there's kind of been a push to do so. However, the range still exists, so that's why we look at a normal range from -18 to -22, depending on the system that you're using. Now, high heart rates can affect or limit your accuracy of strain calculations, and again, as I mentioned earlier, less than 40 frames per second, which can be modified by the sonographer. In our patient, we used Entresto, and Entresto was recently approved back in 2014 based on the Paradigm heart failure trial. I'll talk a little bit about that, have some of their slides. And essentially, as we all know, heart failure is increasing in prevalence given our, whether ischemic, non-ischemic, alcohol-related, etc. So in terms of the definition of HFrEF and HFpEF, LV dysfunction less than 40% is definitive. 14% of it it's uncertain. In between 40 and 50, and then definitive greater than 50% with an EF. With a heart failure preserved LV function. Survival rates among patients with discharge diagnosis of heart failure slightly higher than patients with preserved ejection fraction, but heart failure obviously is associated with significant morbidity and mortality despite having slightly higher survival rates. So it happens as a result of overactivation of the renin-angiotensin system and is detrimental in heart failure with reduced ejection fraction that underpins the basis of therapy. We have the natriuretic peptide system, which causes vasodilatation, decreased blood pressure, sympathetic tone, etc. The sympathetic nervous system with vasoconstriction, vasopressin, resulting in activation of the alpha-1, beta-1, and beta-2 receptors, causing increased heart rate contractility, and then also the renin-angiotensin system with activation of the AT1R receptor, causing vasoconstriction, increased blood pressure, sympathetic tone, aldosterone, hypertrophy, etc. So there's been significant landmark trials with patients with heart failure and reduced ejection fraction, including the SOLVE-T trial with the benefits of ACE inhibitors, the Q trial with bisoprolol, and the CHARM trial, which talked about candesartan, and then we had the SHIFT trial, which looked at ivabradine, and then the Paradigm trial. There was the EMPhASIS trial also, which looked at eplerenone, and then we have the Paradigm trial, which is actually one of the largest, if not the largest, heart failure trial, which is based on Entresto. So I won't go through all the kind of basics of heart failure, as we have looked at these trials in the past just for the sake of time. So CIBIS trial, 34% reduction with bisoprolol. CHARM trial, 30% relative risk reduction with candesartan. EMPhASIS trial, 30% reduction with eplerenone, and significantly reduced risk of CV mortality and hospitalizations. And then we come to Entresto, which is a novel drug, delivers simultaneous neprilysin inhibition and alpha AT1 receptor blockade. It's a salt complex that compromises two active components in the 1-to-1 molar ratio of sacubitril, a prodrug further metabolized to neprilysin, and then valsartan, which we have used for some time. This is kind of how they came to the identification of this agent. So it inhibits it enhances vasal relaxation, and then also, given the valsartan component, which blocks the AT1 receptor, it inhibits vasoconstriction, which results in increased sympathetic tone, aldosterone, etc. So natriuretic peptides are cleared by the NPRC and NPR neprilysin. Let's see if this plays here. Let's see. And these are the things that we are blocking. So we block the AT1 receptor with the valsartan, and we block the ANP CNP system with our neprilysin. Now, bradykinin is a substrate of neprilysin and other vasopeptides. Its elevation has been associated with cough and angioedema. Omeprazole inhibits 3 enzymes involved in the breakdown of bradykinin, which is likely responsible for the development of angioedema. Entresto, if you look at it, only inhibits the NEP134 system there. Study design. It was initially started as a single-blind active run-in period, which then was randomized and became a double-blind treatment period. Median of 27 months follow-up. This is on top of standard of care therapy, which includes beta blockers. However, this did replace the ACE inhibitors and/or ARB that the patient was taking. Inclusion criteria: chronic heart failure and New York Heart Classification 2 through 4 with
muted. Unmuted.
So exclusion criteria: any patients with angioedema, far less than 30, greater than 5, and then requirement for treatment with both ACEs and ARBs, and then symptomatic hypotension, current acute decompensation, history of severe pulmonary disease, and acute coronary syndrome, stroke, TIA, or any major cardiac surgery or PCI within the past 3 months. Their goal was to evaluate the effectiveness of Entresto 200 BID compared with enalapril 10 milligrams BID. Here's where they did our study. So pretty much everywhere. We're going to just go to the end here. So in terms of any adverse event, we have a p-value of 0.03 with significant reduction in when using Entresto compared to enalapril. Summary results: the superiority of Entresto over enalapril was not accompanied by any important safety concerns. Fewer patients stopped their study medications because of an adverse event in Entresto than in enalapril. No increase in the rate of discontinuation due to the possible hypotension related adverse events. Fewer patients in the Entresto group developed renal impairment, hyperkalemia, or cough than in the enalapril group. And the Entresto group had a higher proportion of patients with non-serious angioedema, but Entresto was not associated with any increase in serious edema.
All right, so just wrap things up here. Basically, this patient was very resistant to wanting to take any medications and was content to have an ejection fraction of 40%, with her husband being a personal injury malpractice attorney and making a very difficult position for her cardio-oncologist. And so it was with great interest that we saw something we could treat her with, and when her ejection fraction dropped down to 23%, to give credit where credit's due, actually I talked to Dan Lenahan about this case, and he was the one that said, let's try Entresto. And so, Dan, my compliments to you. It looks like Entresto was very successful in resolving this issue. So, Dan, would you like to make any comments? Dan.
You know, it's probably at least partially relevant to talk about the, you know, for patients with mild LV dysfunction who may or may not be, who may be asymptomatic, then, you know, the data that shows some potential improvement in ejection fraction or prevention of heart failure hospitalization is all based on RAS inhibition. So it's predominantly ACE inhibitors. But then if you add the data from the PRADA study, which was recently reported within this past year, looking at candesartan versus short-acting metoprolol for the prevention of LV dysfunction during chemotherapy, that it was actually the candesartan that was, you know, potentially effective at preventing LV dysfunction. So again, I would say it's more RAS inhibition that's going to be effective for mild LV dysfunction as opposed to a beta blocker. I think that in the case of significant LV dysfunction and certainly symptomatic heart failure, I would say, you know, of course, I'm always going to emphasize carvedilol or, you know, toprol XL or whatever, but that's for people that have symptomatic heart failure. So I think that, you know, this patient kind of fits in the category of, you know, mild LV dysfunction, possibly asymptomatic, and it would make sense if you got to make a choice between medicines that I would go with some sort of RAS inhibition. And then because of Entresto now, we have that as an option. You know, I think that that is, you know, it's a very good drug. So I'm glad it worked.
Okay.
Hi. Sorry, it's just somebody just trying to grab me at the same time. It's Mark Westwood here. Yeah, it was more about the last case really. So just basically just a couple of points on MRI. I mean we've got a massive MRI institute here in London. I don't think I could suggest you could use MRI more as any more than a single point for monitoring. And just a couple of other things. If you're looking for things like myocarditis, you do need to do the scan very, very early after you think the insult has occurred. So if you're seeing the patient and then doing it even 2-3 weeks later, you lose quite a lot of diagnostic accuracy, and probably you need all the latest T2 related techniques for mapping. So it was just those points really, and the final point I completely agree about cardiologist versus radiologist. That's why you'll find we have quite a lot of cardiologists and not many radiologists in our cardiac MRI department here. But it was just to make those points. Thanks.
Thank you, Mark. Mark's an MRI guy at Brompton. Kerry Lindemann would like to say something. Kerry? Okay. Sebastian, would you like to wrap this up for us? Dr. Ping from China. Welcome, Dr. Ping.
Sounds like we're having little connection issues today.
Yeah, well, it's a long way to China.
Eric.
Hello.
Well, Eric, this is a really great case to sort of think about a whole host of issues that we've discussed.
Oh, Zaza wants to know if we have any data on Entresto in patients with cancer. So he says,
No.
you know, this is unprecedented report of using Entresto in a cardio-oncology patient since it's a new drug. Is there any data, Dan?
Nope. I've appealed to Novartis to try to do a small study in that population. They haven't really been all that interested so far.
Okay, well, we will double the appeal, and actually, if everyone appealed, we would have the appeal multiplied by 19.
Yes, absolutely.
So go ahead and wrap her up, Dan.
No, I appreciate it's an excellent case, and we will reconvene next February the 9th, and I will present something from Vanderbilt. So.
Hooray for Dan. Thank you so much for your attendance, everyone. It's been a delight. We do have a recording. The recording will be posted at Cardio-Oncology at some point, also at cardiaccarecritique.com. So we will be editing and posting the recording. Thank you so much for your attention. I know we had some people with unanswered questions. One was Dr. Peng, who did not have a mic to be able to talk, and who's in the USA today. So Dr. Peng, you're welcome to drop in on any of us and visit and say hello. So we'd love to have you come see one of us and wherever you are. And so thank you, everybody. We appreciate it. We're looking forward to next month, and we're looking forward to spectacular attendance as we've had the last two presentations, and certainly featuring Dan, it should be a crowd pleaser and drawer.
All right, thanks a lot, Eric.
Bye-bye.
Thanks everybody for joining in. All right, see you.
Bye, everybody.
Thank you.
Bye-bye now.
By the way, there's a Cardio-Oncology meeting in Israel, June 15th through 16th, 2017.